I was having frequent infections. I had nosebleeds, and I was just severely fatigued. Had some minor back pain, but I wasn't concerned about that. I had never heard of myeloma when I was diagnosed, but I'm learning like I'm 2 to 3 times more likely to get this, but I had never heard of it. But nobody in my family had heard of it. None of my friends had heard of it. So I was really surprised by that. I was having frequent infections. I had nosebleeds, and I was just severely fatigued. Had some minor back pain, but I wasn't concerned about that. I thought I'd just pulled a muscle, working out or something like that. So those were the symptoms that I had. I just chopped it up to, superwoman. As Black women, we superwoman syndrome. You're trying to do everything and be all things to all people. Um, but it was just after a while, the infections, they just got to be too much. And then it was about a pneumonia. And I'm like, something is going on because I should not be, getting these reoccurring infections. And then the nosebleeds, they just kept coming more frequent. And that's what drew me to see my primary care doctor, kind of told her what was going on. And immediately she went and did a blood panel. She was like, let's get some lab work. Let's see what's going on. When I saw her, she did the blood work. She, immediately she was like, something's going on with your protein. And she was like, Valerie, that's out of my arena. I'm not going to even try to guess and tell you. So she referred me to a hematologist, and I was at a just community hospital. I went to see the hematologist oncologist, and I went in. I always told people I went in thinking it was an issue with my iron, because many years ago I had been diagnosed with anemia, and had been taking iron supplements. And I went in there thinking I'm gonna get the over the counter stuff is not working. I need something higher dosage. So I really thought I was going to get a prescription for some iron. Had no idea that it could be anything else. So he started asking questions, and asked to do a bone test, which I later found out was a bone marrow biopsy. And that's when kind of the diagnosis, kind of everything kind of unwound there. Um, but it was, yeah, it was scary, just to go in there and to find out that it's cancer when you think it's just an issue with your hemoglobin. With the myeloma, everything is under control. I visited with my doctors today, and all of my blood work is good, stable disease. I'm not one to use that term remission, when it comes to myeloma, but no evidence of disease. Everything is going well there. Side effects was something that I dealt with, when I was in active treatment. And even I have minor side effects now in the maintenance setting. But I often talk to patients who deal with side effects, but they don't know what to do. And a lot of times they're not always forthright, and they don't share it with their care team, for fear. Sometimes they're very fearful that, if I share with them, they're going to take me off the therapy, or I'm going to have to take a break from a therapy. That means my disease may come back. So I'm just going to tough it out, and I'm just going to suck it up and do what I have to do. And that is one of the worst things that you can do as a patient, is suck it up and tough it out, because you don't have to. When you tell your care team what's going on, there are things that you can do, to help mitigate some of those side effects there. What are some of the current treatment options for relapsed and refractory multiple myeloma?
So this landscape of treating relapsed refractory myeloma is so quickly evolving. We have so many new therapies. In this past 5 years, we've had so many drug approvals for multiple myeloma patients in that relapse setting. So it's a very exciting time. So we have more targeted approaches with proteasome inhibitors like Kyprolis, Velcade. We can use those in the relapse setting. But more novel mechanism of action, so more targeted towards the immune system, so bispecific antibodies for patients who've had 4 prior lines of therapy. And then CAR T therapy, which is another immunotherapy, which is very exciting for patients. And now it was initially approved for patients who had 4 prior lines of therapy, but now we can use CAR T in patients after 1 prior line of therapy. So really these novel approaches to management of relapsed refractory disease.
Awesome, awesome. I know I always get excited when I think of the therapies that we have since I've been diagnosed, and even the therapies that's in the pipeline. It's so much given us so much hope as patients out there. So, Abby, how can a well-balanced diet specifically benefit multiple myeloma patients undergoing treatment?
So, diet recommendations often change throughout treatment based on how patients feel and if they experience any side effects that affect their appetite and or their ability to eat. For multiple myeloma patients who are feeling and eating well, the nutrition recommendations are the same that we would recommend for most other cancers, which is also consistent with the recommendations for the general population. So, plant foods like fruits, vegetables, whole grains, beans, nuts, and seeds contain a variety of cancer fighters, including vitamins, minerals, fiber, and phytochemicals. Phytochemicals are these naturally occurring compounds in plants that have the potential to stimulate the immune system, reduce inflammation, and fight infection, making these foods especially beneficial for patients to consume while undergoing treatment. Protein can also help to boost the immune system, as well as to promote healing and to build cells, tissues, and muscles. We encourage choosing a variety of both lean animal-based and plant-based proteins, including chicken, fish, turkey, tofu, beans, and nuts. The current plant-based eating model recommends filling 2/3 or more of your plate with plant-based foods and 1/3 or less of your plate with animal proteins to create a well-balanced meal.
And are there certain nutrients or dietary patterns that can help manage side effects like fatigue and anemia?
Definitely. So, patients who do experience side effects from treatment may find it difficult to follow a plant based diet to a T. Fatigue is one of the most common symptoms among myeloma patients and one of the most common side effects of treatments. I typically recommend staying as active as you can, eating often and adequately, drinking plenty of fluids. Try planning ahead by asking for help with meal prep, trying meal delivery services, and keeping ready to eat snacks on hand like nuts or granola bars or pre made protein shakes. When it comes to nutrition recommendations for anemia, the truth is anemia is commonly caused by the disease, treatments, or kidney dysfunction caused by multiple myeloma and cannot be improved by diet. However, nutritional deficiencies such as iron, B12, or folic acid can also be a cause. And this can be improved by supplementation, either orally or by injection. It also couldn't hurt for patients with these deficiencies to increase their intake of foods um, rich in these vitamins and minerals, such as turkey or sardines, lentils and beans for iron, again with lentils and beans and spinach for folate, and fish and dairy for B12. I typically encourage patients to talk to their doctor about the cause and plan of care for anemia before making any significant changes to the diet or starting a new supplement.
So one thing that I noticed that, a lot of patients have experienced skin conditions as a result of treatments. One thing that I've dealt with is just the severe dry skin. And I've also had to deal with kind of like hyperpigmentation of the skin there. What are some of the common skin conditions that you all see multiple myeloma patients experiencing as a result of treatments?
Yeah, so some of the treatments we give, because we do a lot of our treatments are subcutaneous injections, so that goes right underneath the skin. So We often will see like injection site reactions. So around the area where we administered the medication, it gets inflamed, red, it can be itchy. So those are your injection site reactions. Other side effects that we see are the dry skin. So for patients experiencing this, and if I know a regimen is going to cause the dry skin, I start telling patients to use those heavy barrier moisturizing creams with the initiation of therapy. So let's not wait till, especially in these long winter months, our skin dries out fairly quickly with the heat. So you want to use moisturizer, again, those heavy barrier creams that can help retain the moisture. So I would start that with the initiation of therapy. With when we see these on-target off-tumor side effects with talquetamab, for example, we can see some hand-foot peeling. So on the palms of the hands and the soles of the feet, the skin starts to peel. So with that, again, these side effects can be self-limiting. We can manage these well. So we use lotions like ammonia lactate to the area. We'll do that twice a day. And this typically will resolve in 2 to 3 weeks for patients. So again, self-limiting. Other things we can see is that nails can get brittle and peeling. And unfortunately, there's not something I can give patients that eliminates the brittle peeling nails. But what I can do is suggest those nail polish hardener lacquers that will at least make the nails stronger, so they're less likely to break for patients. We recommend cuticle oil around the cuticle bed, and we're going to look for signs and symptoms of infection. So we don't want to have any nail infections. Other or side effects that patients can experience, they can have a whole body rash or a localized rash, and we can, depending on the size of the rash, we can manage quite well with topical steroids, these lotions. If a rash is more generalized, the whole body rash, we'll add on a steroid taper. So a course of steroids over several days, and this will tamper down the whole body rash and typically will resolve again in several days. Itchiness. So a rash can be itchy, or a patient will just feel itchy in general. So we can use antihistamines, Benadryl, but also loratadine or Claritin for several days to help with any itchiness that patients have. And then certainly if this is drug induced, and depending on the severity of the skin reaction, I'm going to hold the medication until, these symptoms resolve.
So what are some of the common side effects associated with these newer targeted therapies, Donna?
So because we're kind of activating that immune system, right? So the immune system gets revved up. And what happens is it releases these cytokines. So cytokines are little immune substances that will just be released, and it can cause havoc. So it can literally affect every body system. But typically what a patient will experience is they get the bispecific antibody, and they'll have a fever. This can progress to low blood pressure, can progress to a patient having difficulty with breathing. But these are so well managed now. So the typical patient is going to complain of a fever, almost like when we get our flu shots, we feel a little achy, low-grade fever. This is typically how a patient's going to present. And then as providers, I know this patient's probably having CRS, so which is cytokine release syndrome. And again, the immune system is getting all revved up. And so what I'm going to do is just tap the brakes on the immune system. So we have treatments that will simmer down the immune system. And, the patient usually, we intervene, and within 24, 48 hours, the patient's symptoms resolve, and then we continue on with treatment. We try to mitigate this by giving pre-medications. So we'll give Tylenol, Benadryl, some steroid to help mitigate this side effect. But the majority of patients are going to have this side effect. And so typically we do this as an inpatient, but more and more institutions are learning to manage these side effects as outpatients. So I think we're getting really good at managing these side effects, that we're doing this as outpatient now. And so it's just something that we monitor patients very closely. We're monitoring patients' vital signs, so blood pressure, temperature, and we're intervening at the first sign of a fever, or if I see a patient has a drop in their blood pressure, or difficulty with breathing, we intervene very quickly.
Are there specific strategies you offer for managing side effects like cytokine release and the neurological side effects?
Right. So to mitigate some of these potential side effects like cytokine release and neurotoxicity, we do two things. So first, we're going to do a step-up dosing approach. So we're going to give a small dose for that first dose, a slightly higher dose for that second dose, and then the full dose typically. So we're not going to give the patient the full dose with the very first dose. So we kind of ease the patient into that medication. And then the second thing we do to try to, again, mitigate this is to have a pre-medication on board. So Tylenol, Benadryl, and some steroids, again, to mitigate this and to mitigate the severity. So most patients are going to have that cytokine release syndrome, but it's typically mild. So again, patients presenting with the fever, which we can manage quite well. The neurotoxicity, it happens in very low percentage. So, less than 7% of patients will have this neurological event. And we can manage it. So again, that step-up dosing and the pre-medications can help, but that's something we will manage when the symptoms arise. So I think we have some great therapies we can offer patients. I think the important thing is getting patients through that therapy. So there's side effects. We're going to help manage those patients through their treatment so they can have the best possible outcomes.
And I would encourage patients who are experiencing any of the side effects that we talked about today or outside of today to speak up, advocate for themselves, and let their teams know. The sooner their team is aware, the sooner they can provide supportive care or treatment to help manage those side effects. And if the side effects they experience make it difficult to eat, don't hesitate to ask for a referral to a dietitian if their team has not referred them to one already.
Yes, I agree with you wholeheartedly there. Just speak up and don't suffer in silence. There's no need for that. I have not been on a clinical trial. When I was first diagnosed, getting ready to go for the stem cell transplant, my team did approach me about a clinical trial. But I got through the consent paper and was ready to go with it. But then they found out that it was not going to be a good fit for me. And I was, like I said, I got through the consent, so I was ready to do it. But that didn't come without doing a lot of research and gathering a lot of information about clinical trials and things of that nature, because like most people, I was under the impression that a clinical trial was a last-ditch effort. I was going to be that guinea pig. I was going to get this sugar pill. And all of those things are not true. But that's what I thought because I didn't know any better.
Right.
Now that I've educated myself about what clinical trials is and what it is not, and that there are practices in place now to prevent those things that happened to us in the past. That medical mistrust is a big thing, but people need to understand that there are things in place now to prevent that from happening, in today's time there. So, but yeah, I encourage anyone to consider clinical trials. I think patients should be, that clinical trial should come up in the first few conversations when it comes to talking about treatment options. I don't think it should be talked about when it comes to you're in a relapse or you've had several lines of therapy. I think that needs to be mentioned up front as a treatment option, just like any of the other therapies that's available to a patient.